Hello, everyone. Today we are going to talk about cochlear implants. My name is Maria Roa. I'm studying to be a clinical audiologist, and I'm joined today by Dr. Caitlyn Whitson. To give you all some background on our clinic, for those of you who are new, we are a nonprofit faculty practice of Doctors of Audiology, and we're also a training clinic for doctoral students of audiology like myself. We work with all major hearing aid manufacturers. We're not your typical audiology practice. Most clinics run on bundled pricing, which means that you pay for all of your services upfront, those used and anticipated. We are unbundled, which means that you pay for your services as you go and as you need them. In addition to the typical audiology services, we also provide tinnitus and vestibular specialty testing. We do have two locations. Our main clinic is in Chapel Hill, and then our satellite is in Hillsborough. You may have noticed that in the last slide where I mentioned the services that we offer, that we're a clinic that works with hearing aids, but we don't work with cochlear implants. We are trained to identify when a person might be a cochlear implant candidate, and then we refer out to our colleagues in the hospital sector of UNC Otolaryngology because they are the top experts. UNC's Cochlear Implant program is one of the largest in the country, and they've been implanting people for over 30 years. UNC's CI team performs over 300 procedures every year. So if you're in need of a CI and you are in the North Carolina Research Triangle area, you're in a really good place to be. If you're watching this live, I encourage you to go to our Facebook page at facebook.com/UNCHCC and throw us a like. You can find our YouTube link there since the URL is kind of hard to type out here. And if you're watching this on YouTube, congratulations, that means you found us. So please hit the subscribe button and give our videos some love. Today's topic is quite dense, so we've done our best to condense the agenda into the most essential components. We're going to be reviewing the different types of hearing loss and their treatment options, the candidacy criteria for cochlear implants, what to expect with them, and lastly, we're going to provide you guys some very helpful resources if you're needing some more information with greater detail, or if you're looking for some support. Before we talk about hearing loss, it's very important to understand how the auditory system works. Sound in its most basic component is a sound wave. So sound waves enter our ears and travel through the ear canal and the eardrum. And this creates vibrations in our system. Those vibrations pass through the ossicles or the bones in our middle ear, and then they make their way into the inner ear, the cochlea. The little hair cells that live inside the cochlea move in response to those vibrations, which activates them to release neurochemical messengers that then carry the signal to the nerve, and then from the nerve, it gets sent up to the brain for interpretation, and we get sound. The cochlea is really important for hearing, and there are millions of hair cells living inside. The cochlea itself is shaped like a spiral, and each hair cell inside that spiral corresponds to a particular frequency. So at the very base of the spiral, we've got hair cells that respond to very high frequency sounds, and at the top of the spiral, those hair cells respond to low frequency sounds. And so they're organized very neatly. And as the vibrations come in, they have to find the hair cell that matches to that frequency and vibration. When they find that match, the auditory or the hair cell sends sound to the auditory nerve. And then from there, it gets carried all the way up to the brain. So that's how we hear, assuming all parts are normal. But what happens when things go wrong? Well, then we get hearing loss. One type of hearing loss is called conductive hearing loss. In conductive hearing loss, there's an obstruction in the outer or middle part of our system, of our ears, that stop waves from traveling through the system as efficiently. This can occur when there's some sort of blockage, like a middle ear infection, for example, or impacted wax, which means that sound isn't getting into the cochlea as well as it should. This type of hearing loss can often be medically or surgically corrected. So with some antibiotics, for example, otitis media or that middle ear infection may clear up and no blockage and no hearing loss. When medical intervention isn't warranted, however, sometimes surgical procedures like a stapedectomy may clear up that conductive blockage. If those interventions don't work and the hearing loss remains, then traditional hearing aids are an option, or they could be an option. But in special cases, we might use a different type of hearing aid called a bone-anchored hearing aid, and those are available as well. Sensorineural hearing loss is by far the most common type of hearing loss. Sensorineural hearing loss itself refers to damage or malformation of the sensory or neural hair cells that live inside the cochlea. This causes sound to not be transmitted to the brain naturally, and it's usually permanent. People with sensorineural hearing loss will often describe sound as distorted or muffled. Treatments for sensorineural hearing loss include amplification, like with hearing aids, or stimulation from a cochlear implant. You can also have a mixed hearing loss, which is a combination of the two. So for example, in the case of a chronic middle ear infection, this could be compounded by hair cell damage that was maybe pre-existing. So it's a combination of that conductive component and that sensory neural part that's usually permanent. Sometimes this could be medically treated or reversed surgically, but the sensory neural part is likely permanent. So hearing aids can be beneficial for persons with a mixed hearing loss, but if infections are a cause, then special attention is needed to make sure that the hearing aid use can be successful. So because our talk is on cochlear implants, we're going to be focusing on sensorineural hearing loss, and there are many different causes. We can think about hair cell damage like walking on a lawn. You know, when you walk on grass, the grass will bend, but then it eventually comes right back up. However, if you continue taking that same pathway through a lawn, then the grass starts having a harder time coming back up the way that it once did. And over time, after so much walking and trampling, you kind of end up with these dead areas where grass is just frazzled, essentially. So hair cells are pretty similar to that, in that when they're exposed to too much of a certain something, they get damaged and they can't really rise back up like they did before. The types of exposures that can create this can be attributed to many different factors. So for example, exposure to sound over time can do this to our hair cells. It could also happen instantaneously, though, if the sound is loud enough. Our genetics also affect our hair cells' ability to overcome different types of exposures. So if hearing loss runs in your family, for example, there may be a gene that just makes your hair cells a little bit more vulnerable. Diseases such as measles or the varicella zoster virus, meningitis, mumps, or Meniere's disease can also result in a sensorineural hearing loss. Chemicals from certain medications like platinum-based antineoplastics, better known as cancer-fighting drugs, and even some antibiotics can stomp on our hair cells and create that sensorineural damage. Anatomical malformations during gestation, like a Mondini malformation, which describes a condition where the cochlea is incomplete, can also be a type of cause for sensorineural damage. Chronic conditions like heart disease can compromise our vascular supply to the ear, which is very crucial for these little hair cells to stay alive and keep moving like they should. And presbycusis, which is better known as age-related hearing loss, is the leading cause. We all lose some of those tiny hair cells throughout our life as we age. Researchers now postulate, though, that presbycusis may actually be a result of some or all of these factors combined. So this list is actually not exhaustive. There are other unknown factors that still contribute to hair cell damage and are still being studied and identified today. So sensorineural hearing loss can encompass damage in the cochlea, like from those sensory hair cells, or it could be neural damage, which involves damage to the 8th cranial nerve called the auditory nerve. The inner hair cells that move in response to sound vibrations pass the message to neural fibers in the auditory nerve. Those neural fibers are called spiral ganglion cells, and they're the ones who are responsible for transmitting that message up to the brain. So you may be wondering, if this damage is typically permanent, how do hearing aids actually help you hear? Well, hearing aids are able to magnify those sound vibrations so that the surviving hair cells are still able to convert them into neural signals and pass along that message to the brain. The greater the damage to the person's hair cells, though, the more severe the hearing loss, and the greater the hearing aid needs to be amplified to make up for that difference. However, there are practical limits to the amount of amplification that little device can create. And in addition, if the inner ear is too damaged, even large vibrations won't be converted into neural signals. Well, what defines too much damage? Areas in the cochlea that have no hair cells and or nerve fibers left are referred to as cochlear dead regions. Vibrations that occur within a dead region can't be detected by neurons connected to that region, if there even are any. So for example, let's suppose a case in which the hair cells at the base of the cochlea aren't functioning. The neurons connected to that end won't respond. However, if a tone is presented, it may be detected if it produces sufficient vibration at a close region that's not dead. So in other words, sound can be detected via neurons that are tuned to respond to other frequencies. This is sometimes called off-frequency listening. And off-frequency listening with hearing aids really won't help improve speech clarity, which is the entire purpose of getting a hearing aid, because sound is just too distorted. So a really nice visual of this dead region you could see on the right. We've got a picture of a cochlea from a 25-year-old man that was exposed to gunshots throughout his life. those dark striations represent, oh, let me go back. Those dark striations represent those neurons, but over here, there are no striations in that lighter area. And that is a dead region without any neural fibers left. All right, and I'm going to turn it over to Dr. Whitson so we could talk about how hearing loss is treated when hearing aids are no longer an option.
Thank you Maria for that review on hearing loss and hearing aids. So you can tell by the title of our talk, cochlear implants is going to be the answer to how hearing loss is treated when hearing aids are no longer helpful. So let's talk about that. So when you have a cochlea, we talked about how each hair cell is tuned to a different frequency, and the nerve fibers that attach to the cochlea in those areas are also tuned to specific frequencies. So we need a way to get the sound beyond the missing hair cells and to the nerve directly. So we do that, well, a surgeon does that by implanting an electrode array, feeding it into the cochlea, and it spirals up, and it has different electrodes on it so that each electrode is tuned to a specific frequency that corresponds to around the same frequency that area in the cochlea was set to previously. So cochlear implants stimulate the auditory nerve directly, replacing the cochlear hair cells. So a cochlear implant is a neural prosthetic device implanted surgically, and it provides sound to individuals with severe to profound hearing loss or to those who no longer benefit from hearing aids. So traditionally, you had to be essentially deaf to have a cochlear implant. Those restrictions are starting to be lifted as surgical procedures are improving. There is less and less risk to the individual for undergoing the surgery. So more and more people with less and less hearing loss are starting to be implanted. So as I mentioned, cochlear implants work by sending electrical pulses along this electrode array, and that then gets picked up by the nerve and sent to the brain. So the brain is taking in this signal and recognizing it as sound. It's important to keep in mind that cochlear implants do not restore normal hearing as we know it, but they do provide a useful representation of sound in the environment that most people will adapt to. So there are two main parts to a cochlear implant. There's an external piece that if removed, you're not hearing anymore. When it's put on, you are hearing. And then there's the internal component that's put in by the surgeon. So the external part has a microphone that's picking up sound. It has batteries that either need to be replaced or recharged periodically. It has a speech processor and a transmitter that has a magnet in it. That coil magnet attaches to a magnet that is underneath the skin, which then sends the sound to the internal component and the electrode array. So this is a better diagram showing you how sound can be collected from the microphone, sent through the processor, converted to a digital code, sent through the skin via magnet to the receiver, down to the coil inside the cochlea. So when we talk about cochlear implants and people who wear cochlear implants, we might say, oh, they're a unilateral cochlear implant recipient, or they're a bimodal cochlear implant wearer. Well, those things mean a unilateral cochlear implant recipient only wears one cochlear implant. They may have hearing loss in both ears, or they may have unilateral hearing loss or a normal hearing ear on the other side. They only wear one cochlear implant and nothing on the other ear. Bilateral cochlear implants means a cochlear implant on each ear. Hybrid cochlear implants are newer in the world of CIs, and they are a combination of a hearing aid and a cochlear implant. So they use acoustic stimulation that's going through the ear canal with a little ear mold like a hearing aid and electric stimulation from the implant. Bimodal cochlear implant wearers means they have a cochlear implant or a hybrid cochlear implant on one side and a hearing aid on the other. So hybrid cochlear implants have really come along because surgical procedures have gotten better and better at preserving residual hearing. So if you think of someone like this audiogram here shows, so this line are this person's auditory thresholds. Higher line means better hearing. So low frequencies on the left, high frequencies on the right. This person has really good low frequency hearing, and then it drops precipitously into the severe to profound range in the high frequencies. So we can know that there are some cochlear dead regions in the high frequency range for this individual, but they have really good hearing and not too severe hearing right here that could still benefit from a hearing aid. So a hybrid cochlear implant, or EAS for electroacoustic stimulation, could be really beneficial for this person because they can get a combination of the two. And outcomes tend to be better for people with this type of hearing loss who get a hybrid cochlear implant when their hearing's preserved during surgery. There are 3 major cochlear implant manufacturers. There are lots that are trying to get FDA approval since it's a surgical device. It's very rigorous to get FDA clearance. So the 3 major manufacturers, at least for now, are Advanced Bionics, Med-El, and Cochlear. UNC works pretty closely with Med-El because they have a headquarters in Durham, North Carolina, which is just down the street from us. So UNC does lots of research with Med-El. For single-sided deafness, Med-El right now has the only FDA-approved cochlear implant when you have normal hearing in one ear and a severe to profound hearing loss in the other. So who are the people that need a cochlear implant? Well, as we've talked about before, it's adults and children who either don't or would not benefit from wearing hearing aids. The official candidacy really varies by the institution, the cochlear implant manufacturer, and that person's insurance coverage. Age is not a contraindication to having surgery. So just because you're in your 90s, they won't say, sorry, you're not an implant candidate. Your lifestyle and your general health, your ability to undergo general anesthesia are more important than your age alone. An individual might be a cochlear implant candidate if, when they're using hearing aids, they continue to struggle to understand speech in both quiet and background noise. They can't understand speech over the phone, and they're dependent on lip reading for communication. So if your audiologist suspects you're a cochlear implant candidate, then we will talk to you and recommend going in for a formal cochlear implant evaluation. The evaluation is never a commitment to have surgery, but it's meant to be informational to find out if indeed you are a candidate and for you to be able to make an informed decision about your care. So what does that evaluation look like? So there are a few different examinations, and there's really an interdisciplinary team that works together. So when I refer someone to the UNC otolaryngology, they're seeing an audiologist for pure tone and speech perception testing in quiet and background noise with and without hearing aids to assess how much benefit they're getting from their hearing aids currently. They'll also see an otologist who is an ENT who specializes in the ear. They'll do a medical health assessment, and they'll also order imaging because we need to take a look at the anatomy of the inner ear to see, can we actually put in a cochlear implant in this ear. Occasionally, there will be other assessments. If the person has heart disease, they will need clearance from their cardiologist. So that is determined on a case-by-case basis. Generally, a person is a candidate for a cochlear implant if they have bilateral severe to profound hearing loss, although there are exceptions to this that we've touched on a little bit already. They're not getting benefit from their hearing aids. They have a well-formed anatomy and cochlea that you can put an electrode array into, and they have an auditory nerve, and their brainstem is healthy. Red flags or contraindications to getting a cochlear implant might be if you have advanced meningitis. So your cochlea has become ossified, meaning it's not filled with fluid anymore, it's become all bone. You can't put an implant in something that's completely bone anymore. If there are congenital malformations of the cochlea, so Maria mentioned earlier a Mondini malformation, if there's only a small portion of the cochlea there, well, there's nowhere to put the implant. If there are any lesions on the nerve or in the brainstem, that may be a red flag for a cochlear implant, because you're putting the implant inside the inner ear, and yes, it's making contact with the nerve, but the rest of the nerve up the brainstem into the brain still needs to be able to carry the signal up the pathway. And in some cases, chronic otitis media or chronic middle ear infections are a contraindication, but those are discussed on a case-by-case basis with the otologist. So candidacy criteria really varies based on the manufacturer and based on your insurance, and as we mentioned, based on that surgeon's familiarity with doing the procedure. So if you go somewhere where the surgeon has never done a hearing preservation surgery for a hybrid cochlear implant, they're not going to do the first one on you, most likely. You'll want to go somewhere that does that type of surgery. The surgery itself is usually only about 2 to 3 hours under general anesthesia, and it's an outpatient surgery. Complications are extremely rare. Sometimes there's a possibility of an overnight stay or an observation period, but that depends on the person's individual health concerns. The recovery is about 3 to 6 weeks for the surgical site itself to completely heal, but most people can get back to their normal routine in a few days. The surgical bandage will stay on for about a week, and then there will be a post-op appointment to check on the incision and make sure it's healing well. So after the surgery, about 2 to 4 weeks later is when that person will go back for their activation appointment with the audiologist. So up to that activation appointment, the person is not hearing. They've had the internal component implanted, but it's not until the external component is put on that you actually hear. So at the activation appointment, they'll do an updated hearing test. They'll connect the speech processor or the external component, check the magnet strength, teach you how to use it, and they'll program the implant. Programming a cochlear implant is referred to as mapping. So you'll hear audiologists say, oh, we're going to remap your cochlear implant or something like that. At first, speech can sound a variety of ways. It can sound robotic, squeaky. Some people say that speech sounds like Mickey Mouse, like noise, or it can sound like nothing at all. Some people will recognize speech right away, but it just sounds different. And as the brain adjusts with continued use of the implant, the electrical hearing begins to sound more natural over time. It really takes months of practice and wearing a cochlear implant consistently for the brain adjusts to the new type of electric hearing. Most people reach peak performance with a cochlear implant 6 to 9 months after the initial activation, or 6 to 12 months after the initial activation. So things that predict outcomes for cochlear implant recipients: age. So younger people tend to do better than older adults because they're younger. The brain is more plastic, it adapts more readily. The duration of deafness also matters. Someone could be 30 years old, and in the hearing world, that is pretty young. But if they have had hearing loss for 30 years and not worn a hearing aid, they may not, they can't expect to do super well with a cochlear implant. But if that 30-year-old has spent their whole life wearing hearing aids, they've kept their brain stimulated with sound, you can expect that they may do well with a cochlear implant. Same thing comes for people who've lost their hearing later in life. Maybe they're 65, 75, 85. Since they've had a less severe hearing loss, they've worn hearing aids, you can expect that they may have decent outcomes with a cochlear implant as well, better than a hearing aid that's not providing any benefit. So preoperative hearing levels are also important for outcomes. So I mentioned those EAS or hybrid candidates can do better, and it's just because they have better hearing in some places. So speech understanding is a little bit easier. And the etiology of the hearing loss matters when thinking about outcomes. And those are things that the otologist and the audiologist will talk to you about during your candidacy evaluation. What kind of outcomes you can expect based on your situation and your history. So really the penetration rate for cochlear implants is very low. Less than 10% of people who would benefit from cochlear implants actually get them. And that's for a lot of different reasons. It's also really important that we acknowledge that access to cochlear implants is not equal, certainly not across all races. It's very well documented that Black and Hispanic populations have a huge disparity with access to cochlear implants. And the more awareness we can bring to this issue, the faster we can ameliorate it. So in Atlanta, there was actually a recent study out of Emory University that looked at 10 years of data of cochlear implant evaluations. And they wondered what kind of disparity exists if there is one. And they found that Black patients represented only 18.5% of those who underwent cochlear implant evaluations, despite making up 51% of the population of Atlanta. So this is a huge disparity. Black patients were also found to have poorer hearing compared to white and Asian patients at the time of referral. So something needs to happen where we need better outreach, we need better referrals to be able to address this gap. And it's not just Atlanta. A Texas study also found that non-white patients were half as likely to pursue a cochlear implant surgery compared to white patients. And it's for many different reasons. And we need to look more into these reasons to address these issues. So there's some resources here about cochlear implants. If you're in North Carolina, I really encourage you to look at the UNC Adult Cochlear Implant Program's website. They have fantastic information on there and local resources as well. Cochlear implant Facebook support groups are also really helpful. You can talk to other people who've gone through surgery, gone through auditory training, and they can talk about their experiences. So today we want you to understand that for many people with severe to profound hearing loss, cochlear implants are really the only way to achieve oral communication. Candidacy criteria is becoming less restrictive over time, so more people than ever can benefit from cochlear implants. If you think you might be a cochlear implant candidate, or you're not sure, or you just want more information, talk to your audiologist about a cochlear implant referral. If your hearing aids are not providing adequate benefit in your life, you should seek help sooner rather than later, because I do see in my patients sometimes a point where it is too late people cannot safely undergo surgery anymore, and they're left with hearing aids that they can barely hear from. So you can learn more about cochlear implants through that link, and I will be posting a PDF of our slides in the chat box here, so you can download it if you're on our live Zoom session. At this point, I'm going to stop the recording and we will take questions in the chat box. So if you're watching this on YouTube, thank you for joining us today. Check out our channel. We have lots of other interesting videos for you to watch.